All right, welcome everybody. Greetings everyone. Welcome to the third part of our new webinar series in partnership with the Montana Natural History Center and the University of Montana, The Age of the Coronapocene. I'm Jennifer Robinson, Education Director for the Montana Natural History Center, and I'll be the host of this webinar series today. Our co-host again will be Drew LaPier, our Montana Natural History Center Museum Programs Coordinator. She'll be working in the background and available to answer questions and address comments using the chat box. Please let her know if you have any technical difficulties or questions during the webinar. During today's webinar, we're also going to be streaming through Facebook Live as well. So if you have any questions through the chat function through Facebook, we'll also be monitoring that and responding to your comments. Similar to the first two episodes in our series, this webinar will again be supported by closed caption capabilities. The wonderful Caroline Habish will be working in the background to provide text for our speech if you need assistance in following along with the program. Please click on the link in the chat box. We will put this link both in the Facebook Live chat scroll as well as the webinar scroll. This will open up a separate window where you will be able to read what is being said on screen as we are speaking. Please note that the view cap for the closed caption is only 50 individuals. So please only use this assistance if you need it, so we have enough space for all who require closed caption assistance. Throughout the webinar, we will repost this link multiple times in both places for those who might join late and need that assistance. Back with us today are members of our expert panel of scientists and educators from the University of Montana, and they're ready and excited to start more discussions about the science behind the novel coronavirus, COVID-19. As a reminder, our panel are not medical doctors and will not attempt to try or diagnose symptoms in this program. Later in the program, the audience will have an opportunity to ask our panel questions about the virus and living with COVID-19, but note that we will not be taking questions for those seeking medical advice. Please seek medical help if you have questions or concerns about your own health. So back with us today, we have Assistant Professor Brandon Cooper from the Division on Biological Sciences at the University of Montana. He is an evolutionary geneticist and population biologist who studies host microbe interactions and conducts research on bacteria used to control human disease transmission. Today's discussion will focus on Brandon's presentation of the future of COVID-19 spread and uncertainty surrounding it. Also presenting today is Associate Professor Rosalyn LaPier, who will be transitioning us into a deeper discussion next week, focusing on misinformation and how Native communities are impacted by COVID-19. During the question and answer portion of the webinar, we'll be joined again by Assistant Professor Angela Lewis. Today's webinar will focus on social distancing, uncertainty about COVID-19 into the future, and answer many common questions about where we are going next as the pandemic continues. Brandon Cooper will start us off, and then we'll turn it over to Dr. LaPier before transitioning to a question and answer session. During the Q&A, you'll be able to ask the panelists questions and have them answered live. To ask questions, you can use the chat box or the Q&A feature of Zoom. If you're watching us through Facebook Live, you can also ask us questions through the Facebook chat. We will be monitoring those and we'll pass those on to our panelists through the webinar to get those questions answered. If you ask a question during the webinar before the Q&A starts, we may have one of our panelists answer your questions via chat. So be on the lookout for that if you ask one sooner, but we'll also have some questions answered live later in the program. To let us know of any technical difficulties or to communicate with myself or the co-host Drew, please use that chat box. So let's try and use that feature now for those of us that are new, and we'd like to know where people are tuning in from. Go ahead and type into the chat box where you are watching us from. We're currently broadcasting from Missoula, Montana. Let's see where folks are from. Okay, we've got folks watching in from Missoula, Iowa, Montana, Anaconda, Moscow, Idaho, that's exciting. Arizona, Moab, Utah, Broomfield, Colorado. Wow, that's great. We've got folks coming in from lots of different states this time. That's pretty exciting. Awesome. Thank you so much for sharing. Feel free, if you haven't had a chance yet, to continue to let us know where it is that you are tuning in from. Oh, we had a quick question there in the chat. I'll go ahead and answer that now. After the webinar is finished, it will be recorded and uploaded to our YouTube channel for the Montana Natural History Center. I'll go ahead and have our co-host Drew copy the link to our YouTube channel in the chat box. And at the end of today's program, we're also going to be copying that link into the chat box as well to direct those of you to the recording. It won't be made available immediately. It will take a little bit of time to render, but it should be up by the end of the day. Okay, let's go ahead and jump in and get started. I'm going to turn it over to Brandon Cooper. Can you start us off and tell us more about questions and uncertainties surrounding COVID-19?
Sure. Thanks, Jennifer, and everybody for being here. Can you hear me fine? Yeah, good. Yeah, so like Jennifer said, I am an evolutionary geneticist and assistant professor at the University of Montana. I'm not an infectious disease epidemiologist or a virologist, but I do work on tangential topics and I'm deeply interested in COVID spread. So I thought today it might be fun to talk about some of the uncertainty that we all have, the way we might see the new normal, what do we expect coming in the future, the sort of questions that I'm getting, that I have, et cetera, and I think might lead into an interesting discussion in the Q&A portion of this. Yeah, so I think the big question that most of us have right now is when will things return to normal, right? So we now have community spread of COVID in Missoula here, where I'm presenting this in most parts of the country. We've been on lockdown and we have a lot of questions about what's going to happen moving forward. I think some of the specific questions we have centering around COVID spread and the uncertainty there: when can we lessen social distancing? What will happen when we start to get active? Why is testing so important? We keep hearing about testing and we know we're doing some, but why is the amount of testing we need to do so important? Why can't we just open everything back up now? I've certainly been asked this question and I know people are wondering. How might COVID-19 spread differently in different areas? For example, if you live in New York City versus a place like Missoula, Montana. Is this event surprising? So are scientists surprised that this is happening? Is it out of the ordinary? Do we expect this sort of thing to happen again with a different pathogen? In terms of COVID, once it's come through with the first wave, do we expect it to come back again later this year? And then finally, how can we be better prepared for future pathogens moving forward, if this is something that's going to happen? So Prof. Angie Lewis gave a great talk last week, and I hope people saw it, but if you didn't, I'll cover a couple of things that I think are useful to know right now. So she talked about this, this thing we call R0, which is the average number of people that each infected person infects. So you could think, she described as, if I'm infected and there's an R0 of 2, on average, I'm infecting 2 more people. And she showed this slide, which gives you some insight into what we think happens when we put particular interventions in place. So let's say that we have an R0 of around 3.5, which is showing here, and then the different shapes are showing different types of interventions. So what might happen if we close schools, or if we completely isolate ourselves, if we have social distancing of different types. And on average, what we expect is that those things are going to reduce R0, or the number of people we will infect, right? Because if we're infected and now we distance ourselves, it's less likely that we're going to interact with someone and pass that infection on. So this can be an important thing to have a handle on. How many people is the average person infecting? If we look at just some data from Montana, what are the impact of interventions? So what I'm showing you here is time on the x-axis and reported cases on the y-axis. You can see this red line that's going way up real fast and exponential growth there. That's predicted increase at R0 equals 3. So if we just say how would something spread at R0 3, that's what we would expect. And then I've put in a line here on Prof. Lewis's graph showing when Governor Bullock issued his stay-at-home order and how that influenced the reported cases that we were seeing. And so you can see that we put some stay-at-home order in place and we start social distancing and we see a reduction in the cases, right? So these things work. So this is sort of a local analog to what we would, what I showed you on the last slide from Angie's talk. So I think we see these patterns, right, of we've gone through this tough part of social distancing. We start to get some evidence that things are going down. And many of us are wondering, so it's time to get back to normal, right? When can we get back to normal and start getting active and interact with our friends and get the economy going again? It's not a perfect one-to-one, but I think we can look in the past and we can ask some questions about, well, what happened the last time we had something like this going on? And that is, I think we can get some lessons from the 1918 flu about what happens whenever you start to lessen social distancing. So I'm going to first show you some data from St. Louis in 1918. So on the x-axis here, we have time. And so you can see that's going from September towards December. And on the y-axis, we have deaths, some proxy for deaths. We'll just consider it deaths for this. Below the time on the x-axis, I have these blocks there that are showing you the period of time that schools were closed. So where it says school closure down there, you can see that schools are closed a little like mid-October through, say, mid-November, and then they open them back up. And it was similar for a public gathering ban. So what happened in St. Louis when they lessened the social distancing is that the case numbers started to go back up. They obviously saw this, and then they put school closures and public bans back in place. But you can see that the second increase in the number of deaths actually was higher than that first bout that they were dealing with there. So this shows you that if you release social distancing, maybe at a point that's too early, you can see people get active, and then cases go up, and then subsequently the number of deaths go up a little bit later. But the same thing doesn't always happen in the same place, right? So if we look at New York City at a similar time point here, so again, we have the same sort of graph with time on the x-axis and deaths on the y-axis. Here, the measures they had in place were just isolation and quarantine generally, and you can see that those were put in place at a similar time as we saw in St. Louis on the last slide. But the real difference here is that they left those in place until the deaths were down towards zero, near zero, right? And then around December 1st, you can see that they stop isolation and quarantine. When that happens, you do see some cases come back, or deaths in this case here, but not nearly as much as you saw in St. Louis, right? So this gives us some insight, at least in 1918, what happened in different places whenever we decided to go back to school or to come out of extreme social distancing measures. So let's come back to COVID-19. So I'm just showing you a sort of similar graph here where we have days since 100 cases on the x-axis, and we have new daily confirmed cases on the y-axis. The first thing you can see here is that the United States has many more cases than all these other areas that are down at the bottom that include Italy and United Kingdom and those sorts of places. But you can also see that those new daily confirmed cases is plateaued and is at least not increasing there. We don't know yet exactly what's going to happen on the national level in terms of if that's really going down. But there is some evidence that what we're doing is working, right? And that's great. But I think when we see this sort of success, that instantly leads people to start to say, okay, so when can we get back to normal if this is working? But it's complicated, and geographic variation makes it complicated in a country like this and in many others. So here I'm showing you a similar plot with days again on the y or on the x-axis, and then the new daily confirmed cases on the y-axis. There is a difference in this plot that I'll mention, in that there's a log scale, what we call a log scale on the y-axis. The difference here is that you see it going 10, 100, 1,000, 10,000. So many more cases up here in New York than you have in Montana due to that log scale. But what you can see is that the new daily confirmed cases, if we just look at the US data, we get one picture, but if we look at all of the different states, there's a lot of variation in terms of the new daily confirmed cases we're seeing in different states. We can also see for those viewers in Montana that we look particularly good, right? And I think a lot of this has to do with, we are a rural state and it got here a little later, but we also employed social distancing measures quite early. And so we didn't see a real rapid rise, at least we haven't so far. Okay, so we see that we're making some progress. There's this geographic variation among states. So what now? What are we going to do? You probably know that the Trump administration has released some guidelines on how to open up America, and you could Google those, and there's these various things they call gating requirements. There's a report that came out before that called the National Coronavirus Response, a Roadmap to Reopening by Gottlieb et al. And the American Enterprise Institute. I'm going to talk about that one. These things are all similar, but I think this one's particularly reasonable, and they all speak to the sort of things that we want to see happening as we start to lessen social distancing and what we're worried about and the things that we're uncertain about as we begin to do that. So each of these have various phases. So phase one from the reopening report of Gottlieb et al. Is slow the spread. So you can think about this as where we are now. So COVID-19 gets to the United States. It's initially spreading from people coming in. We then confirm community spread throughout the United States and in most communities, or at least in most states and communities within those states, there's some variability in that. Point is, you got pervasive community spread, and so you instantly need to employ social distancing, and that's been done across the country, right? So we see it spreading, let's distance ourselves and try and lower that R0 value that Angie introduced last week and that I introduced in the beginning of this talk. So let's reduce our interactions to reduce the probability that we pass on an infection to other people. So we're doing a pretty good job of that in Montana and some other places. Phase two, you can think about as a state-by-state reopening. And I have here, Montana on the front line, and I'm just saying that based on the data. If we're going to open on state-by-state, we look particularly good right now. And we now know this week that Governor Bullock announced a plan for reopening carefully. So what does that mean when you get to something like phase two, and how do we think that we might be successful there? Well, we need to diagnose, treat, and isolate cases and their contacts. Right? So if we open up and we're not paying attention, all it's going to take is for a case to pop up and to spread to get us back to community spread and potentially back to a situation where we need to employ social distancing. And the reason that is because the vast majority of the population is still susceptible, right? If COVID starts to spread through a community like Missoula, most people are still susceptible. Most people haven't had it yet. And a lot of that's because we've been really good at the social distancing. So we need to be able to catch those cases, treat them, isolate them, and then very quickly find people they've interacted with. Because remember, with COVID, you're passing that on before you have symptoms. And so it transmits very well. So by the time you start to feel sick and you go into the doctor and we get a confirmed case, we know that there's a good chance you've been passing that on to people for the last 3 days. So we need to quickly find them, give them tests, and identify all of those interactions that could have led to potentially more infected people. Phase two, still no large gatherings. I'm sure that this will vary a certain extent by places, but if you're wondering, will I be going to that concert next month? The answer is almost certainly no. What those numbers will be, whether or not it'll be, groups of 10, groups of 50, whether it'll get larger than that, I think is going to vary. But on average, large gatherings are going to remain very difficult. Sensitive groups, limiting exposure is going to remain necessary. So I think if you're an elderly individual or if you're someone that has any sort of health issues that might make you more susceptible to COVID-19, just because people say, okay, we can become more active, I think it's going to require people in those groups to remain cautious, because remember, you're still susceptible. And if we do get COVID spreading and we don't catch it and you get it, that wouldn't be good. So sensitive groups are going to need to limit exposure more than others probably. Public hygiene is going to have to be improved, deep cleaning. So if you see places around the globe that are opening up, those that are having success after outbreaks or after initial spread, you're seeing them employ measures for public hygiene. I think we've covered it at some point, but if you don't know, COVID-19 can remain viable on some surfaces. So plastic, for example, you can find viable virus for up to 3 days. And so it's going to be really important when we start getting active, and especially in high traffic areas, that we're employing good public hygiene. Also, wearing a fabric mask is going to be recommended. And we'll talk a little bit more about this later, whether or not that's going to be something that works around here. But generally speaking, and by works, I mean, will the public do it? It would absolutely work if people do it. It's not going to prevent you wearing fabric masks from getting it, but it will prevent you, reduce the probability that you pass it on. And so if we're all wearing masks, that's going to improve our ability to get active and reduce the chance of additional spread. And then finally, phase 3, you can think about this as, when we have a vaccine or similar things that are making it safe for us to completely lift distancing. So I have here, they have in the report, broad surveillance. So lots of testing and contact tracing, therapeutics. So things you can take that are not a vaccine, but that can reduce the negative effects of COVID, and or vaccine deployed. I think you can think of phase 3 as really being whenever we have a safe and effective vaccine that's being deployed. You probably heard that we're over a year away from that, but that'll be when we have a vaccine and we can safely go back out. How effective vaccines are, there's a lot of stuff that would be interesting to talk about with vaccines. I'm not going to talk about that today because it's not my expertise, but we do have local experts here at Montana that are working on this specific topic, like Professor Jay Evans, who I think may be having some similar things like this in the future that you could ask him questions of. And then we may talk about herd immunity in the question and answer session if you have questions about that too. So what are we seeing around the globe as other places start to open up? Well, we're seeing they're being quite cautious and sometimes not cautious enough. So in Singapore, things look pretty good, but you're seeing recently that they closed workplaces and schools as COVID-19 cases jumped again. So one thing to keep an eye on around the globe is if you want to know ways that things are going to happen in the US, is just look at what's happening as other countries, states, local areas open up, and look at those that are having success and those that aren't. And that will be informative for what we do moving forward. That includes Europe. So you have Europe that got this before us. You have a variety of approaches that have been employed in Europe. And so we can take a look at those that are easing restrictions or that remain in full lockdown or those that have no lockdown and see how that's working and the measures that they're putting in place. So I really think a way forward, in addition to making all of our own plans, is keeping an eye on what's going on in other places of the globe as they reopen and the things that and places that are particularly successful for making that happen. So this is all great, but what we really want to know, right, is what's going to happen in the US, what's going to happen where I live, how's this going to affect me, can I lessen social distancing in my community, et cetera. It's really hard to predict these things, and there's this quote that many people have heard, essentially all models are wrong, but some are useful. We can leverage these models, but as you've been seeing, there's going to be some variance in what they put out, and we're doing our best to predict these things. But I thought I would talk a little bit about some of the uncertainty surrounding that issue. So for example, we brought up this topic of R naught, but just knowing R naught is not going to tell us exactly what's going to happen. So epidemics with similar R naught can have drastically different outcomes due to local demographics, variability in secondary infections, et cetera. So two things you probably heard about: the 1918 flu, which we've talked a little bit about here, infected 500 million, Ebola infected only 30,000, but both of those had a similar R naught of 2, right, with very different sort of outcomes. We don't know what R naught is for COVID-19. Angie may in the Q&A have better thoughts on that than I do right now, but we don't know exactly what it is. We don't know how much it's going to vary among regions. But what we do know is when we do have good estimates, there's still going to be uncertainty in the outcomes. Okay. And again, that has to do to local demographics and other things that the simplest models just don't include. There's also uncertainty in how it's going to affect places in terms of the density of people. So is it an urban area, suburban area, or a rural area like many people on this call may live? It's to be determined the way that COVID is going to experience us differently in those areas and in subsequent waves that come through. There are some data coming out in China that are taking into effect the how crowding, so how population density leads to the intensity of epidemics or how long those epidemics last. And generally what you see is a sort of, I think to me at the beginning, a counterintuitive result that less dense, more rural areas can have more intense outbreaks. And that just means that you see in those areas that you get a real sharp peak that goes up, whereas in more urban areas, you can get that rise, but then the epidemic can last for a longer period of time. So the curve is broader, and that's what these data are showing. So on the left side, if you're looking at the x-axis, you have the mean population crowding. So how crowded is something going from little crowded to very crowded. And on the y-axis, you have how intense that epidemic is. And there's a general negative trend. It doesn't explain a lot of the variants, but we can seem to say that crowding seems to matter. So from these data, I would just say that the way in which you're going to experience COVID-19 spreading or coming back is going to vary geographically in ways that are complex. So what are some of the barriers to our success moving forward? I mean, there's lots of them, but these are some of the things that I'm thinking about. Like I mentioned earlier, the vast majority of the population is still uninfected. There's an error there. New cases are going to arise, and those infections will spread until they're caught, right? So the vast majority of the population is susceptible. They haven't had it. And so in many ways, when the next one pops up, it's going to spread as easily as it did the first time. Barriers to success are testing. You know, we have lots of testing going on, but we do not have nearly the amount of testing we need. That includes the things we've been talking about, is what we would call RNA testing. Those are the things that are looking for the virus itself, and they're using these approaches you may have heard called RT-PCR, where they're looking for that RNA from the virus. So you look at those in people that are still infected. And then we also need antibody tests. Those are what we can use to say, did you have it in the past? And for something like COVID-19, where it seems like there's lots of asymptomatic infections, there's a real question about the proportion of the population that's been infected in different areas. And we really need antibody testing to figure that out. It seems like it's going to be from less than 5% up to 20% in the States, or at least some of the studies coming out are showing that, but we really need that. Contact tracing, we're going to need that. That's going to be a real barrier to success because, again, whenever you go to the doctor with symptoms, you have had this for a period of time. You have likely been transmitting that to other people. So when we find out you are infected, we need to instantly identify people you've interacted with. And if we're not good about catching infections and we're not good about tracing down people that infected people have interacted with, we can very quickly find ourselves in a position where you're getting a local outbreak from that. I think there's also some barriers based on public resistance to distancing measures, mask wearing, et cetera, right? I think we've done a good job, but I do worry about how long people are willing to employ these measures, or are people willing to wear masks and do these things? So we'll see how that works. And when you're dealing with exponential growth, as Angie discussed last week, good decisions are going to often feel silly. So whenever you shut things down when there aren't very many cases, so if we see if we see COVID-19's returned and we're starting to get cases and you see people are worried and shutting things down, that's because if you wait to shut it down until you're really at exponential growth, you're going to get many, many more cases and deaths than you would if you shut it down early. But that's a barrier because you're going to always be, when you're doing a good job, making decisions that look silly at the time, in my opinion, when you're dealing with exponential growth. Okay. So the good news is that we will defeat COVID-19 in my mind. I mean, there's lots of people working on vaccines and therapeutics. That is going to happen, but I thought it might be good. I've had people asking me questions about uncertainty about after that, right? So is there another one coming? You know, and like I said, is COVID-19 going to come back and that sort of stuff? So what we know about coronaviruses themselves is that there are 7 human coronaviruses that have been described. 4 of those are circulating, and those are some of the cause of the common cold. Okay, so these account for 15 to 20% of what we would define as the common cold, and those are 4 coronaviruses that fall in the alpha coronavirus and beta coronavirus groups. We also have these 3 others that you've now heard of. So CoV-2 is the one we're talking about now. And then you also have SARS and MERS. Those are recently emerging things that you've heard about in the news in the last 2 decades. So SARS, MERS, and CoV-2 likely emerged from bats, but were transferred to humans via an intermediate host. So we don't know exactly the way this happened, but the genomic data, all the data we have suggests that this came from bats. Intermediate hosts are not currently known. There's greater than 500 coronaviruses that have been identified infecting bats in China, but it's estimated that there are several thousand more. I've seen estimates up to 5,000 or so, right? So these things are out there, and The risk of transmission is going to always be high for animal workers, people that are interacting in these wet markets and things like that. So these are there. We know they're there. So it's really a matter of if they jump to humans. If we look at the three that have emerged in the last 2 decades, with SARS, you had about 8,000 cases and 774 total deaths, and that epidemic has ended. MERS, there were 2,500 cases, 866 total deaths. Infections still seem to be occurring for MERS. And then COV-2, as of earlier this week, we're approaching 2.5 million cases and 170,000 deaths. So, I mean, I think we absolutely are not surprised and expect more that are going to come. It's just a matter of when, where, how, what, and all of those sorts of things are the uncertainty that we have, not will we deal with pathogens again in the future. And to sort of impress upon you about why we're not surprised, I mean, we have on these exact things we're talking about, a paper in 2015 warning us called "A SARS-like cluster of circulating bat coronaviruses shows potential for human emergence." So this is why funding basic research and working on these things constantly is super important, right? Because we want to be characterizing these things. We want to know they're there. We want to identify things that we think could present future problems that can help prepare us for when those things do get into human populations. So some closing thoughts and questions that I've had, I think many of us have. I'm not saying these are the best answers, but this is what I would say to each of them. When can we lessen social distancing at least a little? I mean, this is going to happen soon in Montana, as those of you know that watched Governor Bullock's release, and it's unclear if we're ready. So I want to say that cautiously. So it is true that we have done a good job of flattening the curve. And in fact, we look better than about any place in the country, maybe the best. When I say it's unclear if we're ready, I think that is the uncertainty I have in terms of how are we with testing and contact tracing? Are we going to be able to catch the next one that pops up? Next question, when can we lessen social distancing completely? I mean, anytime between now and 2 years, not between now and 2 years, I'd say between 1 year and 2 years. It's going to be at least a year probably before we have a vaccine. You want those to be safe and effective, and then they've got to go through trials and be dispersed and all that. So those things take time. So I would just say up to 2 years. Will reductions in social distancing lead to more cases? Yes, absolutely. But how many depends on whether we catch them early and often, right? It's absolutely true that if we never leave our homes, we won't get this. And it's absolutely true if everyone leaves their homes, more people will get it. The question and the uncertainty is around the different measures that we employ locally and nationally and internationally, and which ones work, right? Will additional waves of COVID-19 hit the US and Montana? I mean, I guess we don't know for sure, but I would say yes. And the outcomes depend on when we catch them and how we respond to those, right? So if we don't catch them, then we're in trouble, right? We're gonna be right back to where we are, and we're gonna have to employ these sorts of things that we're doing now. If we have lots of testing and we're able to catch them and then able to do the contact tracing, maybe we can make it through without going back to full social distancing. That's why contact tracing and testing is so important. Without it, we won't catch the next thing, and it could turn into an outbreak. Will this happen again? Well, like I said, there's lots of coronaviruses out there. Those are I only talked about coronaviruses and bats right there, but there are lots of other pathogens, viruses and bacteria. Absolutely, other pathogens are going to be a problem for us. It's just a matter of what those will be, when they pop up, how severe they are, how well they spread. You know, all the stuff we've been trying to figure out about COVID-19 and how to deal with it. All of those things we'll have to revisit when the next thing comes. I just hope that we're more prepared to do that after going through this. And then finally, how can we ensure that all groups of people are prepared, protected, and that we have some equity here? Because there's already data coming out showing that different groups of people are experiencing this in different ways. And so I think it's important for us to look at the way that we have various things put into place to try and deal with COVID spread in a way that is equitable and is useful for different types of people in the country and around the globe. And with that, I think Rosalyn's actually going to talk about that.
Great, thank you, Brandon. Thanks for that rich discussion into the future of COVID-19 and answering some common questions about where we might go next. So as Brandon said, let's turn next to Dr. Rosalyn LaPier, can you share more with us about misinformation and how this impacts Native communities?
Okay, thank you. So I'm not actually going to be addressing misinformation that much right now, but kind of jumping off of Dr. Cooper's discussion about when can we get back to normal, and sort of what are those questions related to that, and especially looking at Native populations in Montana, but using the Native populations in Montana as an example of other Native populations in the West. So first, as a reminder to folks who are not from Montana, but Montana is a state that has a large Native population similar to other states in the American West. We have 8 reservations here in the state of Montana, and we have 12 tribes. The majority of our tribes in the state of Montana utilize a separate public health care system called the Indian Health Services. If you've not heard of it, it's called IHS. And unfortunately, the Indian Health Services is a federally funded program that has been chronically underfunded for many, many years. And that creates an issue when we have health concerns such as this, such as COVID-19. And the other thing I want to mention, when you look at this particular map here, the state of Montana also is next to the country of Canada. And the vast majority of tribes in the state of Montana are split by the Canadian and US border. So there are tribes on both sides of the border. So for example, Kootenai up there in the corner, there are Kootenai that are in Canada, there are Kootenai that are in the United States. If you move right over to that, the Blackfeet, there's Blackfeet or Blackfoot in Canada, and there are Blackfeet in the United States. So the Canadian border at this time is closed, but it is a border that for many tribes is something that is kind of an artificial border because tribes are split by that border. So there is a lot of travel back and forth between families, communities, for religious practice, cultural activities all the time. And so that potentially becomes an issue when we start thinking about the ways that we address COVID-19 or other types of epidemics or pandemics. So as Dr. Cooper had mentioned already, one of the things that is occurring right now in terms of the phase 1 in Montana and elsewhere is, the effort there is to slow the spread. And because tribes are sovereign governments and sovereign entities, they can create similar or separate systems of addressing these types of public health care issues. And so in the state of Montana, again, as similar to many states across the West, tribes have their own state of emergency declarations. And as part of those state of emergency declarations, they can create different types of systems, and they have. So in the state of Montana, for example, we have, as part of our state of emergency systems in different tribes, we have the stay at home, similar to the state of Montana. We are also addressing elders as part of one of the high priority populations within tribal communities. So elders for many tribal populations, that's kind of the treasured, members of our community. And so because of that, a lot of the efforts to slow the spread are geared towards elders and geared towards children. But for an example, in terms of how do communities communicate also with their elders, I gave an example on my slideshow here, which is actually from Alberta Public Health Services. Again, remember the Canadian-US border is kind of fluid for many Native people. And this is a public health care awareness in the Blackfoot language that the Alberta Healthcare Services put out that gives the same information that we would see in English, right, in the state of Montana, but is being shared in Blackfoot. But other tribes doing similar services where they're creating different types of public health care information that is either monolingual or bilingual, so that they can address those populations within their own communities that where English may not be their first language. One of the things that tribes are also doing in terms of trying to slow the spread is, again, because tribes are sovereign entities, they can implement curfews, they can implement border crossings, they can close their borders, they can fine people for not practicing some of the ordinances that they have implemented. And so tribes are beginning to do that. For example, the tribe that I'm from, which is Blackfeet, we do have a curfew in place. We do have a process where people cannot drive around the reservation unless it's for essential services, and they can be fined. You can get a fine from the police for driving around, say just for fun. One of the things that tribes also do is that instead of looking to the non-Native American public health services as their guide, they usually look at what's going on with other tribes. And right now, unfortunately, one of the hardest hit Native American communities are communities in both Arizona and in New Mexico. And so Montana tribes are looking towards those tribes to see what is occurring there. We have similar demographics here in the state of Montana as the state of Arizona and the state of New Mexico in terms of the percentage of Native population to non-Native population. But as you can see, this was an article that just came out this morning from The Guardian that was talking about how Native numbers are not, and the Native population demographic is not being included in some of the coronavirus data, but listed sort of as other instead of as Native American. And so one of the things we're seeing, for example, is that in Arizona right now, 16% of Native Americans who were tested and reported to have COVID-19 unfortunately died from Corona-19. That is a very, very large number. 16% is a very large number. And so again, when you're looking, when Native tribes are looking at what is occurring in their state, they're not often looking at the state population numbers, they're looking at other tribal population numbers or demographic numbers to see what is going on. And in New Mexico, as you can see, although Native Americans make up less than 10% of the population of New Mexico, they're already a third of the coronavirus cases there in that particular state. Again, these are the numbers that tribes look at. So as Dr. Cooper had mentioned, even though the state of Montana is doing a really great job in terms of controlling the coronavirus, the spread of coronavirus at this point, tribes are thinking about this differently. So as Dr. Cooper had mentioned, this week, our governor, Governor Bullock from the state of Montana, presented a reopening plan, but the vast majority of tribes still in the state of Montana said that they were not going to follow the state of Montana's reopening plan. They were going to follow what was best for their own communities. And on the slide right here, I'm just sharing a couple of examples of what two different tribes in the state of Montana have shared with their own citizens about how they're going to address COVID-19 within their own communities. As you can see, the Blackfeet tribe is still going to keep their state of emergency going. And the Little Shell tribe has reminded people that the Little Shell tribe does not have any healthcare system for their tribal members, and that there's no vaccine yet, people are not immune, and so people still need to take those precautions. So I think I'll end right there. You know, tribal communities are still asking those same questions that Dr. Cooper had presented, you know, kind of when will things get back to normal? except tribes are thinking about it very differently than, say, the state of Montana and kind of the non-native population, because there is a different history there, and it is a different demographic. And so because of that, tribes are thinking about it differently and just being much more cautious than the non-native population. So I think I'll leave it there, and Jennifer, we can open it up for questions and comments to our audience. Thank you, everyone.
Great, thank you, Dr. LaPier. That was awesome to listen to what Native communities are doing in the pandemic right now with COVID-19. So as she mentioned, it is time now to open it up to questions from the audience. And I invite viewers both from our Facebook live feed as well as within the Zoom webinar platform to ask us any questions that you have, either about anything that you've heard today or about the COVID-19 coronavirus in general. We also have Angela Lewis here with us as well, and she can answer questions from our panel as well as Brandon Cooper and Rosalyn Pierre. So let's go ahead and use the question and answer feature or the chat box right now to ask a question to our panelists. If your question is accepted, we will share it with our panel. As a reminder, we're not medical doctors and will not take questions to diagnose any symptoms. So it looks like, let's see, do we have any questions coming in yet? We've got a couple here. Here's our first one. Okay, so we have why bats? They seem to have a disproportionate amount of viruses. Is that true? If so, why? This question might be best directed towards Angie.
Sure.
Thank you.
Yeah, so this is actually a really big question among disease ecologists right now. Are bats really special? Because they do seem to have a lot of things. And actually some of my research comparing bats as hosts to rodents, what we find is that they do seem to host more viruses per species than bats do. But not total number of viruses more than rodents do. Sorry, I said that wrong. So bats per species host more than rodents do. But if you look at total, we've identified more rodent viruses because there are just more rodents out there. And so why might bats be important? There's a lot of things that people are looking into. They have some interesting things going on with their immune system and their physiology. They're the only mammal that flies. They reach really high body temperatures while they're flying and really high metabolism. And all of that can kind of affect how viruses grow within the body, and it can affect how the immune system works. And so it's actually a really big, still open question about are bats really special? And if so, why? But it's a super interesting topic.
Great, thank you so much. Here we have another one. Is it clear what counties in Montana are going to open schools when the time comes? This one might be a bit more.
Yeah, that's true.
Brandon?
I think that's hard to predict right now. The way I understand it is that at least in the state of Montana, Governor Bullock has sort of delegated that to local areas. So you'll see superintendents thinking about that. And then ultimately, I think that would be a decision that's on school boards. I suspect, I'm totally guessing, but I suspect what will happen is that I would guess most will not open up this year, and then the summer will be spent trying to figure out ways to do on-site stuff, probably in some hybrid way. And I think that answer applies for higher education too. It turns out to be a really challenging problem that anyone involved with education anyway is trying to figure out right now.
Great, thank you. That is a bit of a difficult question to answer. We kind of just have to wait and see what ends up happening with that. Okay, we have a question here in the chat box through Zoom. Can anyone explain, and maybe Rosalyn, this question might be geared towards you, why Native Americans seem to have a higher rate of infection than other groups?
I think I'll try to answer it, but I think I'll also open it to the other panelists as well, as to why certain populations might have a higher incidence of COVID-19 than other groups do. We are seeing that also right now with elderly populations as well. And usually it's similar, which is that usually there are higher levels of underlying other health conditions that usually depends on tribal community to tribal community, that they don't have access to the same level of healthcare as other communities do. One of the things we're seeing, for example, on the Navajo reservation, 30% of the Navajo people do not have running water. So when you're asking people to have high levels of, daily washing your hands and hygiene, if you don't have running water in your home, then that's not going to happen. So there's a lot of different levels to that, and it's usually a multiplicity of underlying conditions that make that happen. But I'll open it up to other folks who may also want to answer that question.
Yeah, I'll just say, so the way the question was worded, it was, why do Native Americans have higher rate of infection? I would say, I don't know that we actually know they have a higher rate of infection, that they're more likely to get infected, but they seem to be more likely to have those severe cases that would lead to hospitalization and then death. And so then that would lead to what Rosalyn's talking about, all these inequalities based on healthcare. And if you just have lower health standards in general, or not standards, but lower care in general, then it's going to make you more vulnerable to it being severe if you are infected.
Yeah, we really need those antibody tests that I mentioned to figure out who in the population has been infected, because you're going to always catch the ones that are, well, not always, but usually catch the ones that are quite severe. And so we get those counts, but then, we may have lots of asymptomatic infections in young age classes where there's higher infection rates than we know, just because we haven't seen them. And so, yeah, to be determined, but those things are really starting to happen right now.
Great, thank you for that clarification. Going back to the end of Brandon's presentation, you mentioned a little bit about herd immunity, and you had also mentioned that Angie might be able to share a little bit about this. We have a question here. Can Dr. Cooper, and I imagine Angie as well, talk more about herd immunity and how possible it is that a vaccine will bring us to this?
I'll leave this to Angie and then chime in. I think she's the expert here.
Okay, so this term is being batted around quite a bit, and there's probably a lot of people who don't really understand what that actually means. So the idea of herd immunity is that even though if I'm still susceptible, so I haven't been infected myself, I might be protected and have herd immunity if enough people around me have already been infected and are recovered. And so if everyone else that I'm coming into contact with, or at least most of my contacts, are with people who are immune, then the chances of getting the infection is really low. And so you call that herd immunity. So even though I'm still susceptible myself, I'm protected by enough people around me being immune. And so we can actually quantify the proportion of the population that needs to be immune in order to protect the uninfected. And it's a quantity that's 1 minus 1 over R naught. So that means that if R naught is 2, that you can achieve herd immunity if 50% of the population has been infected and is now immune. Or if you have a vaccine, that means that 50% of the population would need to be vaccinated in order for everyone else to be protected. And so that's the idea of herd immunity, and that would be the goal if we had a vaccine, would be to vaccinate enough people to where we protect that proportion of the population. So if R naught is 3, so around here it's probably between 2 and 3. So if R naught is 3, that would mean we would have to vaccinate about 2/3 of the population. And so that's what that means. You can also apply this to kind of natural spread and think about what's the proportion that would need to have been infected in order to get things to drop off and protect the rest of the population. And there it's slightly more complicated, but the same idea works. But it does lead to a large proportion of the population having to be infected and then immune in order to protect everybody else.
Yeah, and the only other thing I'll say is I've seen some people talking about, a strategy of letting natural spread get us to herd immunity, but you don't have to take a very careful look at the models to know that that's going to be a really bad outcome, right? Because with these sort of measures we put in place, maybe we don't know, 5% of people who have been infected, maybe up to 20%. So your options there would be able to let it just completely swamp the healthcare system to get there fast. Sounds terrible. Or it's not going to come for multiple waves, which could happen each time, getting a little more and a little more. So when you see people talking about that as a strategy for dealing with this in terms of natural spread getting us there, I would be very skeptical.
And I would just add to this discussion, again, when you look at certain demographics in American society, and I'll use Native Americans as an example, even with a seasonal flu vaccination, there are very low numbers in Native populations getting the seasonal flu vaccination. And that, again, that's for a multiple of reasons. And so that idea of quote unquote herd it doesn't happen in certain populations because we can't get those numbers high enough. And so when we now hopefully will have a COVID-19 vaccination within the coming year, hopefully all of our different demographics and populations in our communities are able to get it at a high enough level so that those populations are able to be covered and it doesn't keep being spread. So.
Great, thank you. Okay, so to kind of add on to that, is there any indication of how long immunity will last for those people who have been infected?
I don't know, you want to chime in on this, Angie? I mean, my answer would be we're cautiously optimistic that through the time of vaccine development, I think would be what I would say right now. We don't know. I'll say I don't know, but from what I've read and what I understand, we could be hopeful that it would get us through that period, but it's totally unknown how long exactly.
Thanks. Angie, I saw you nodding your head in agreement there. Okay, so we have a couple more questions here. One of them is about UV light and heat. So how important is UV light and heat in breaking down the virus? And will this be helpful as the Northern Hemisphere heads into longer days of summer?
I'll quickly answer that question by saying, join us next week when we try to address some of those questions.
Yeah. So I think, we don't have a great, there's some conflicting evidence, right? When you go and you look at a place and you see spread in Miami when the weather's hot and everything else, it makes you question it. There's some evidence out there that spread might lessen seasonally like other things do, but I would say we don't know. The things we do know, I think what Rosalyn's hinting at is that using UV light or things like that for treatment methods, as has been in the news recently from the administration, is there's absolutely zero evidence for those sorts of things and catastrophic health consequences if you were to take those recommendations as treatment.
We have our own.
So, sorry, I didn't hear you. I don't know if it was me, but I didn't hear you. Sorry.
Oh, I might have forgotten to unmute myself. I'm sorry. We have one more question. There appears to be tests in other parts of the world. Why are we not using them here? And why do we need to come up with our own?
I mean, I think, I don't know the full history on that, but I can speak to it. I don't know why the CDC decided to do what they did specifically, but it's certainly true that I think the WHO and others were releasing tests that work. The only thing I will say is that this isn't a super complicated thing. I mean, with the sequence, we could go down to my lab and run tests pretty easily. So this, I think it's been described in the media a little bit like that this is this super complicated thing. And so I was a little surprised to see that early on the things we would call primers that they were using were not super great, and the test had these very basic problems that any first or second year graduate student in my lab would be able to work out. So that was surprising to me. I don't know on a level in terms of the politics or implementation why we chose to go this way or another way. I will say that despite all that, getting to the numbers we need to do to test enough people to safely go out into life without lots of distancing, that's going to remain a challenge. That's just a hard thing to get going.
Thank you. Would anyone else like to have any final thoughts on that before we go?
No, but I see something in the chat. Someone mentioned research at the Rocky Mountain Lab in Hamilton about sanitizing face masks using UV. And yeah, so UV can kill virus on surfaces. It's not going to be helpful for any kind of treatment for people, but UV can kill viruses on surfaces. It's just that most people don't have access to like a UV lamp and use it properly to where you're not going to be hurting yourself, like your skin and your eyes. And so it's totally practical in a lab setting, but probably not so much around your own home.
Yeah, and that's a great point and great question, George. I was speaking about sort of how the virus viability might vary as a function of UV exposure and seasonality and things of that sort.
Great. Thank you so much for finishing on that note there. Well, folks, that just about wraps it up. Thank you to all of our viewers today. We had some more really great questions, and we're going to continue this discussion. Again, we are going to have a fourth showing here of our webinar series. We had originally only advertised for 3, but we are going to have a fourth one next week. And we're going to continue that next Friday at 3 p.m. Mountain Standard Time. A recording of this webinar and the previous 2 weeks' webinars will be available on the Montana Natural History Center website and our YouTube channel. Our co-host Drew will post the links for those in the chat box. So next week, for our 4th episode in the series, we're going to be transitioning into deeper discussions about misinformation. Dr. Rosalyn Pierre mentioned that briefly before her presentation earlier today, and she's going to be diving deeper into the different kinds of information that's been circling around about COVID-19 and addressing some of those pieces of information as either misinformation or information, and how COVID-19 relates to the history of viruses affecting society. So thank you to all of our panelists. Thank you to the Montana Natural History Center and the University of Montana for this partnership in our new webinar series, The Age of the Coronapocene. Have a safe and fun, socially distanced weekend, everyone, and see you next week.